Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. Now, if you are hearing this right now, then you are not currently a Journal Feed subscriber, and so will not be receiving the full Journal Feed podcast, only getting a portion of the past week's articles. If you would like to get full access to both the podcast and the blog, then you'll have to become a member. All the details for that are at journalfeed.org. And remember, we never want money to be a barrier to better patient care, so if you're having any trouble affording a subscription, just get in touch. We'll help you out. This is the audio version of the past week summaries, which were brought to you by our authors Joshua Belfer, Seth Walsh, Alexander Turner, Ketan Patel, Megan Hilbert, and Clay Smith. In a spoonful, neither the pediatric risk score nor the Carpe Diem score as pneumonia tools were very good at predicting radiologic signs of pneumonia in children. I would not recommend that you use these in practice. Certainly not to replace your clinical judgment. Okay, let's skip straight to the second article, titled The Effect of Treatment with Balanced Crystalloids versus Normal Saline on the Mortality of Critically Ill Patients with and Without Traumatic Brain Injury, a Systematic Review and Meta-Analysis. Many of you will know that there has been a lot of back and forth between balanced crystalloid fluids and just giving normal saline and which one is actually superior. It hasn't been super clear, but it seems like overall for critically ill individuals requiring resuscitation, that if you use balanced crystalloids, that you're going to be a little bit better off for those patients, better kidney outcomes, and even better mortality for these patients. So in general, I tend to favor balanced crystalloid solutions. However, when we saw the BASICS trial a couple of years ago, which was a big trial looking at these things, we saw that in the TBI cohort, there was a benefit to giving normal saline. So potential harm with balanced crystalloids if we're switching over to that route for every patient. So this was worth looking at. And these authors did a systematic review and meta-analysis of 15 RCTs to look at this outcome. Now, unfortunately, not all of the RCTs were going to answer the question about TBIs, which is what they were really most interested about. However, we did see a confirmation that generally in critically ill patients, if you're giving balanced crystalloids, that there is a decrease in mortality. Now, what they found when they drilled down to the TBI patients was an increase in mortality, just like in the BASICS trial. And that gave an odds ratio of 1.31 for mortality at 90 days. Meaning that you should be giving normal saline in these patients. This is interesting. Of course, the cohort of patients that were actually included in the TBI part was much smaller than the overall part, but all the same. Now, if you just took all the patients all pooled together, then you saw no statistical difference between the two. So it's possible that all this time, part of the reason that we haven't been seeing a difference between normal saline and balanced crystalloids in general, in larger studies, perhaps was because of the harm that we were causing to TBI patients. So maybe in future studies, these two cohorts should be separated because perhaps they're not the same. Now, why is this better for these patients? Why is normal saline better? I don't know. I mean, we do give them a lot of hypertonic saline, and there tends to be a higher sort of osmolality of giving normal saline. So perhaps that's what's a little bit beneficial for these patients. I can't say exactly. There are a lot of reasons why a TBI patient could be hyponatremic and might need a little bit more sodium, but it's hard to speculate without further data. And even from just this study, there's definitely some flaws here. While it was just looking at RCTs, which we do associate with being high quality data, they were not all looking at this outcome specifically. Of course, this is a subgroup analysis of many other trials. And often 90-day mortality wasn't the primary outcome of those trials either. So we're getting a lot of kind of subgroups here. It would be better to have a dedicated RCT on this subject. However, for myself in the meantime, given that I'm not totally convinced that it's going to make a huge difference either way, I might just bias myself towards giving normal saline to my TBI patients. It's really not that hard to do, and it might not be that effective. It might not be a huge difference. So either way, maybe I'll just go that way. I doubt I'd be doing harm, so I figure until I know better, why not? That's the best I know. In a spoonful, a meta-analysis of RCTs showed normal saline to be better for TBI patients in terms of 90-day mortality. That's above balanced fluids. And this is opposite of the general population, where pretty much every other critically ill patient seems to benefit from balanced fluids. Okay, let's skip over to the fourth article, titled First Attempt Success in Ultrasound-Guided versus Standard Peripheral Intravenous Catheter Insertion, the EPIC Superiority Randomized Clinical Trial out of the JAMA Pediatrics. Now, typically when I think about an EPIC RCT, I'm thinking about the treatment of COVID. However, this one was just on pediatrics and looking at ultrasound-guided IVs. Now, putting an IV in a child is no simple task. The success rate, even in a pediatric emergency department, looks at about 50% on your first try. And in speaking with anesthesiologists, at least in adults, the expectation is that you have at least an 80% first attempt success rate, otherwise you just kind of suck at putting IVs. And this, of course, matters more in children than it necessarily does in adults because it causes a lot more pain. Well, not necessarily more pain, but a lot more anxiety in these children, which, of course, we want to avoid. They're just kids. And when I think about trying to get a really good first pass success on putting in anything into anywhere in the body, really, I think about ultrasound. So it's worth questioning whether or not every IV that we place in a child should be an ultrasound-guided IV first try. This has been looked at before, but mostly in the context of difficult intravenous access. And in this trial, they looked at all levels of whether or not it was going to be difficult or easy to put an IV and saw if it helped all comers. So these patients were randomized to either the regular group, palpation or visualization of a vein, or the intervention group where they did ultrasound-guided IVs. There was nothing special about how they put these ultrasounds in. There's a nice little table about how to basically guide your needle in the article, and it's really the basics of the stuff, nothing fancy here. And actually, unsurprisingly, what they found was more successes if you use the ultrasound on the first pass. So 86% versus 32%, which is a huge difference. And it really varied a little bit across the different difficulty assumptions about how that IV was going to go in, but all the same, we're really superior here with the ultrasound. And the ultrasound also did better in a lot of the secondary outcomes. So the number of insertion attempts, better with the ultrasound. The total attempts that were required, better with the ultrasound. Patient-reported pain, better with the ultrasound. Consumer satisfaction, better with ultrasound. However, the dwell time and the device removal due to failure rates were similar between the two, which we wouldn't expect to really be that different because often that's not a result of how it went in, but rather other factors. You might be asking about the healthcare costs, and I'd say that a $10 difference is a trivial difference, even if it was a little bit more expensive for the ultrasound group, when all the rest were better for these kids. Now, despite the fact that we have this, or just a single trial on this, this would be something that would probably be a lot of work to implement in an emergency department. However, give it some thought. I personally, since I place very few IVs myself, I just ultrasound guide everything, but I only try to get IVs once everyone else in the department has failed. None of the nurses can get it, and then it falls to someone like me. So I just get out the ultrasound right away because I assume if they couldn't get it, I'm not going to get it. They're better at it than me. In a spoonful, first attempt success was higher for Peds peripheral IV insertions, regardless of difficulty when you used an ultrasound. Okay, that's all the articles that we covered from this week. Let's do a quick wrap up of everything that we talked about. And from the second article, consider favoring normal saline resuscitation in your TBI patients for a small but significant improvement in mortality seen in the systematic review and meta-analysis. And then from the fourth article, first attempt success for pediatric IV insertion was higher if you used an ultrasound regardless of the difficulty. Again, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles about? Well, we did a comparison of risk tools for pediatric pneumonias. We looked at an observational study that gave us details about the Jerix-Herxheimer reaction after treating syphilis. And we did a review of all things trauma in pregnancy. Links to all the articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.